Okay, so what we're going to talk about then is our anesthetic technique. And I'll give you some background that most people who have anesthesia in the world have a standard type of anesthesia. The drugs can vary a little bit, but I think you said you had a surgical nursing background? So most people, as you may know, have gas anesthesia plus narcotics for pain medicine. So they breathe in what used to be ether, and then was isoflurane and enflurane, and now sevoflurane, and some kind of gas anesthetic plus pain medicine. That's morphine, Demerol, Dilaudid, narcotics like that. Okay? And that's a terrific technique. It's used very commonly, but both of those two drugs, the gas anesthetics and the narcotics like morphine, have two problems. And they're funny, they both have the two same problems. And one problem's annoying, unpleasant, and awful, and no fun, and the other's deadly. Okay? The gas anesthetics, because they're fatty chemicals, tend to dissolve into the fat, and when they do, and you wake up afterwards, there may be some residual chemical left in the fat. So when you wake up, some of that chemical can come back, and you can have postoperative nausea and vomiting. The gas anesthetics cause postoperative nausea and vomiting in about a third of patients. So 1 out of 3 is going to be waking up retching. So you work in a surgery center? You've seen them retching out there in recovery, right?
Yeah.
Okay, we don't want that. Annoying, not deadly. The other thing the gas anesthetics do is they come back is they can cause some unexpected and unpredictable sedation. They can decrease your drive to breathe, decrease oxygen because you're not breathing as much. Then you get some pain medicine for pain, and all of a sudden you get low oxygen, irregular heartbeat, and sudden cardiac arrest. And so I hope you guys didn't see it very often, but every once in a while in the recovery room they have stat, Dr. So-and-so to the recovery room, Miss So-and-so's not breathing, and then it's crash, bang, give me a bag, okay. That's respiratory depression, low oxygen, and that's a complication which is fortunately uncommon, but can happen with the gas anesthetics, and we don't like that. So gas anesthetics, nausea and vomiting, respiratory depression, don't like it. Narcotics, wonderful drugs because they take away pain. Love those drugs because they take away pain. But narcotics, nausea and vomiting in some, okay? And it's a respiratory depression. It decreases your breathing. In some cases, pain, obesity, abdominal surgery, anesthetics, and narcotics for your pain, breathing slows down, breathing may stop, irregular heartbeat problems, low oxygen, cardiac arrest, potentially death. So the anesthetic technique we use is a combination of things to protect against the annoying nausea and vomiting and the potentially deadly respiratory depression. So we use TIVA, or total intravenous anesthesia, using something called propofol. It's that white milky looking stuff that they give, and it's not a respiratory depressant. It's not causing nausea and vomiting. It does not cause nausea and vomiting, and it has a short offset and it doesn't store up in the fat. So that's a good thing. In addition, we use a very short-acting drug while we're there so we can wake up. Now we do still rely on some narcotic pain medicine, but there's a hot new area of research called opioid sparing anesthesia. The idea there is, can we come up with drugs that will decrease our need for narcotics? And we've come up with a batch of those drugs, and they include a brand new drug called dexmedetomidine, an old-timey drug called ketamine, which we use a little bit of. And ketamine and dexmedetomidine, along with another group of drugs, increase respirations and protect you from nausea. So we use a very specialized anesthetic technique. Our patients are really happy, and when we've measured, we've decreased the need for pain medicine, we've decreased the incidence of nausea and vomiting, and it's a very safe technique, and patients are very happy with it, as you kind of saw here this morning. Other questions?
So we're